Greetings, my name is Andrew Gonzalez and I'm an assistant professor of vascular surgery at Indiana University. I was raised by a single mother in Chicago and I quite literally grew up in the shadow of the Cook County Hospital. She was the institution's first black female attending and worked tirelessly to provide high quality care to complex patients. Aside from being a good clinician, she also impressed upon me the need to make changes at the policy level in order to influence population health. To this extent, I received formal training in law, medicine, and public health, and eventually earned a JD, MD, MPH. I believe this provides a unique perspective on equitable technology development, and this is further honed by my clinical training in general surgery residency and vascular surgery fellowship, where I had the opportunity to serve patients at 2 county hospitals, 4 state university hospitals, 3 VA hospitals, 3 level 1 trauma centers that served racially diverse but economically depressed communities. I also completed an NIH T32 fellowship at the University of Michigan, where I learned quantitative analysis to better understand hospital quality. Specifically, I wrote hundreds of thousands of lines of code to implement Bayesian hierarchical modeling and other techniques necessary to identify high quality versus low quality hospitals. Currently, I practice at Indiana University, where on a weekly basis I operate at the county hospital, the state's only quaternary referral center, a VA hospital, a local outreach hospital, which serves a largely rural population consisting of mostly farmers and factory workers. I think this provides a particularly unique lens by which to understand technology development. In this context, I propose developing an equity-grounded approach to computational phenotyping for peripheral arterial disease. PAD affects 8.5 to 12 million Americans, and each year 150,000 Americans undergo lower extremity amputation, the majority of which are potentially preventable. My proposed objectives for the Diagnostic Excellence Program are first, to gain experience in domain adaptation for a large language model to PAD, and second, to pilot a clinician-centered, equity-conscious framework for AI model development and testing. Concerning the first objective, we will fine-tune a language model on 2 tasks. This large language model will perform autonomous PAD screening based upon pain descriptions from unstructured provider notes. We believe this is feasible as we have over 124,000 patients with several million provider notes. We plan on developing a PAD-specific information retrieval and summarization system to essentially allow the model to show its work for why it came to the conclusion it did in the autonomous screening arm. These directly address 4 of the failures in the diagnostic process identified by the National Academy of Medicine's Improving Diagnosis and Healthcare Report. Specifically, we address information gathering, integration, interpretation, and the need to establish an explanation for the healthcare problem. Perhaps our most interesting aspect of this work is piloting a human-centric, equity-conscious framework for evaluating AI clinical decision support tools. Specifically, we will benchmark model performance along domains that build clinician trust in AI systems, mostly that deals with eliminating hallucinations. We will use the RAGOS industry standard metrics to evaluate our models for accuracy, relevancy, and safety. In terms of disparities, we'll identify and address differences in model performance across race, octogenarian status, and female gender. Each of these 3 groups have been shown to be at higher risk for late or misdiagnosis in peripheral arterial disease. So how does this improve clinical diagnosis? Well, clearly it addresses the issue of late and misdiagnosis for this common and highly morbid condition. Additionally, it develops the back-end technical capability for the development of further passive digital diagnosis systems. This might come in the form of clinical nudges, such as provider alerts, or as fully autonomous systems for referral to the vascular lab. Beyond the research, I hope to engage in 2 other activities that will potentially impact this project. The first is to engage with federal stakeholders who are operating at the intersection of AI and healthcare. The second is to work with my specialty societies, the American Heart Association and the Society for Vascular Surgery, to build a coalition around the task of autonomous PAD screening. I believe that this research agenda is potentially sustainable in terms of funding because there are multiple R01s from the NIH as well as AHRQ looking at using digital health interventions for clinical trials, for data curation at scale, as well as a tool for improving health equity. In conclusion, I believe that this proposal addresses many of the issues in Chapter 5 for health information technology raised in the Improving Diagnosis and Healthcare Report. Specifically, we're designing an intervention that demonstrates usability, human factors knowledge, measurement capability, works within a clinical workflow, and facilitates the timely flow of information.